So our agenda really is, we're probably not going to be able to answer every single question that folks did ask us, and I was humbled by all the questions, but we're hoping just to really get into talking about some of the sleep changes that can occur in midlife related to menopause. How can CBT be an option for you, and how can you get yourself started on a program? So to set the stage, I thought it would be important just to go back and briefly talk a little bit about, menopause and what is it. I know we're hearing a lot about it in social media and in other places. That's pretty much all my feed seems to be about now. And really what it is for folks that still have a uterus and still have ovaries, we're looking at menstrual cycles often, and it's a retrospective diagnosis that occurs really one day in a person's life. And many of these classifications that are used by clinicians really do tend to focus in on what's happening with the menstrual cycles. So if you've ever looked into this at all, you might have seen something called the Stages of Reproductive Aging Workshop, or the STRA criteria. So that is really commonly used, and effectively what it does is it tries to say what's happening in somebody's body with their ovaries and uterus that might tell us if someone's reached menopause. So it is a retrospective diagnosis. So effectively we're looking back to say, how do we know someone's in menopause? Well, we're looking to see if they haven't had a period effectively for a 12-month span. All right, so that's really what the menopause is. And so if you don't have ovaries, or you had them removed, or if you don't have a uterus and you've had that removed, then obviously this type of classification system might not necessarily apply to you. So in terms of the terminology, we have what's known as our natural menopause. So that's a loss of our ovarian function or the follicular activity. The average age of menopause in Canada is about 51 years, but 90% of folks will have reached menopause between the ages of 45 and 55. Some people actually will have an induced menopause, so maybe that's something that creates a toxicity to the ovaries themselves, or they've had to have their ovaries removed. Some folks have had a hysterectomy, but at times we do have to clarify and ask, what do you mean by that? Because some people might actually have their uterus removed, but their ovaries are left behind. So not everybody who has had their uterus removed has had their ovaries removed. So sometimes clinicians might clarify that with you. And there's other reasons. I think we're finding more and more with autoimmune diseases is that some folks can also have this impact their ovaries as well. We're learning that with premature menopause, which typically occurs before the age of 40, so somebody's had their last menstrual period or their final menstrual period before the age of 40. Old estimates for how often this would happen were about 1% of the population, but now I think we're learning that ovarian insufficiency can occur in around 2 to 4%, and I've also seen ranges up as high as 5%. Early menopause happens between the ages of 40 to 44. That's estimated to be about 10%. And then late menopause will be for those folks that happen after the age of 55. I will also say that in different countries, these estimates are different. And for example, in India, I believe the average age of menopause is about 47. So there can be differences depending on where you're at in the world. There's been a lot, I think, in the media and the news about perimenopause. And when we think about menopause, the perimenopause, it's really a transitional phase. And there is also a term that is sometimes used interchangeably, which is the menopause transition, although they're not completely the same, because perimenopause also includes that time period that's up until that 12-month period after the menopause. And what can happen during this phase is that people can start to experience symptoms. It's said that the mean age of perimenopause is about 47, but that's a question mark because it's estimated to be an average. Folks can also start experiencing changes with their menstrual cycle. Now, again, if you don't have a uterus, that wouldn't necessarily be the case for you. But often what happens in the early perimenopausal period is that there's often, greater than or equal to about a 7-day variability in cycle length. Now, that's in those that would have had regular cycles. And that's consecutively and or symptoms at least twice in a 10-month period. And then in the later perimenopause, as we're getting closer to that, technical menopause date, folks notice that they might have greater than or equal to 60 days of amenorrhea. And that phase can last 1 to 3 years. So during that time, if folks are seeking help from clinicians and you're getting asked a lot about your periods, if you still have a uterus, then this is in fact why. Otherwise, if you don't, you will be relying on speaking to the symptoms that you might be having if you don't have a uterus. So it's important for us to reflect on this because that the life expectancy in Canada is pretty long. If you make it to age 65, it could be that you live another 22 years. And when you look at the average age of menopause on top of that, many folks who are assigned female at birth will spend nearly about 40% of their lifetime in a postmenopausal state. It's also important to notice that even after you've technically had your menopausal date with your last menstrual period, it can take a couple of years after that time point for the hormones to actually kind of stabilize and level out. So there is a little bit of a period of discontent, shall we say, in terms of hormonal regulation, even after the final menstrual period. So I wanted to go back to basics just for a little bit and do a superficial overview of the relationships between our ovaries and our brain and just how important these feedback loops are and how they're really responsible for the communication of these hormonal symptoms in our body. You might, if you see any readings, they'll talk about brain areas known as the hypothalamus and also the pituitary and how that talks to our ovaries. So really, the menstrual cycle itself is controlled by a series of hormones that initiate and regulate growth in the endometrial lining, the development of an egg, its release, and then possible implementation of the egg, and if pregnancy does not ensue, completing the purge of the uterine lining. And then we have that repeat in a cyclical process. So we're not going to get into a whole lot of depth here about the different, feedback mechanisms and how there's positive and negative influences. But some of you might see in the diagram there and recognize some of the acronyms, FSH being follicle stimulating hormone. So that's really what's getting the follicle production geared up, and ultimately it's what eventually is going to cause the release of the egg. You can see estrogen is really critical in there. And we're going to talk in a little bit about, actually the next slide, about production of progesterone as well. So when we have a normal menstrual cycle, what folks could expect is that we have across the top there, you'll see a follicular phase followed by a luteal phase. The follicular phase is really building up that the endometrial lining or the proliferation or the thickening of it, and estrogen is produced from the follicles. And really in that second phase, what you'll see is after ovulation, we have that corpus luteum, and that is really the source of progesterone, and it helps to convert the lining into a secretory, stable endometrium, which limits further proliferation, and it really helps to stabilize that uterine lining. And obviously, if then implantation doesn't occur, the progesterone withdrawal occurs when there's no egg fertilization, and that would trigger the menstrual bleed. As we approach the menopausal transition, we have aging follicles, the ovary ages, there's fewer follicles available. Follicles themselves may still produce estradiol, but ultimately what happens is without the corpus luteum formation, we really start to see a decline in progesterone. So this is something that tends to happen before we have, or earlier than we see in terms of estradiol decreases. And so that's really important to note, and we'll talk about later how progesterone may also be a molecule, I guess, that helps some folks with their sleep. So for folks that have a uterine lining, as we just mentioned, estrogen continues to stimulate endometrial growth. And then without the progesterone, the lining doesn't mature normally. We end up with a lining that can be fragile and disorganized, and then we can end up with irregular shedding. So that's why we often see these issues in terms of somebody's cycle. So people can end up with heavy bleeding. They can end up with changes in their cycles being either prolonged or irregular, or they can end up with breakthrough bleeding. How this does relate to sleep is that sometimes some folks might say, I actually flooded through a pad or something during the night and, actually had to get up and change. So abnormal uterine bleeding can be a significant issue in terms of quality of life for folks. And I would say that there's a lot of different reasons why folks can experience abnormal uterine bleeding if you still have a uterus. For example, fibroids, But hormonally speaking, because estrogen is still stimulating the growth and with the less progesterone, the uterine lining itself really isn't the same as it used to be and is a bit more chaotic. So when we approach the menopausal transition, and I'm sure some of you, if you're on social media, you've seen a lot of information about how estrogen itself can be quite erratic. So that's not a great diagram. I just made that diagram myself. It's not, accurate, but it just basically shows that perimenopause often brings irregular ovulation and with it as well some unpredictable estrogen levels. And for some folks during this time who are experiencing symptoms, it might be a shared decision making process that they might speak to their clinician about, actually just trying to shut the cycle off, to try to suppress those ovulatory cycles that still could be happening and to help try to stabilize those hormonal levels. And it may also help them with things like irregular bleeding, hot flashes, and different things like that. Although pregnancy is less likely during these hormonal changes, I think it is really important that if you're in this stage and you're not wanting to get pregnant, then you should speak with your healthcare professional. There have been studies that would look and see that there are some things that can happen called luteal out of phase, or sorry, out of loop events. And basically, what's happening is ovulation can still occur, and sometimes when not expected. And so it's really important that you're thinking about what is happening in the body with the cycle. Is estrogen still being produced? Or am I still ovulating? Is there a chance I could be still ovulating? And that might actually help if folks are looking for symptom control if they're having some menopausal related symptoms. Another note, and I see this sometimes, and it is a myth that, doses of what we would traditionally say as menopausal hormone therapy are not the same as contraceptive doses. And so when folks are using MHT or menopausal hormone therapy, it's not the same as a contraceptive to prevent ovulation. So that's just something to note. So that was really a quick drive through there of just thinking about all the different hormones and mechanisms that are at play, how our brain is really talking to our ovaries and vice versa, and really trying to, create communication pathways, ultimately that points to, as humans, the goal of reproduction. But as I mentioned with ovarian aging, and not producing follicles anymore, we really do start to see and experience some of those changes that are associated with perimenopause, menopause transition, and then the postmenopause. So let's switch gears and talk about sleep changes in midlife. I really want to point out that, and I'm sure individuals here on the webcast are probably very familiar with this. If you're in this stage of life or past it, there's really no one menopause journey. You can pick up any article. This one was in over 480,000 middle-aged women, looking at, what are the prevalence of different things that are happening for them. And you can see in this particular group that sleeping problems was about 52% of the group. And it's very similar to other large studies that I've seen reported. Of note, there are folks that will go through this transition in life, and maybe 1 in 4, 1 in 5 may not experience very many symptoms or anything that's very debilitating. But for the folks that do, it can be significant and it can really impact their quality of life. So I think sleep is often one of those things that for a lot of folks ranks really high when they're talking about their perimenopausal journey or their postmenopausal journey as a problem. So they're common and they rank as some of the most bothersome symptoms for folks. If you're interested, Pauline Mackey, who's the lead author there on the first reference mentioned, she does a lot of amazing work looking at sleep and is based in the US and has a lot of different publications. And I've also seen that sometimes she has some webinars available as well. So she's a really excellent sleep scientist. So when we talk about sleep issues in midlife and the menopause, we often think about difficulties with falling asleep, staying asleep, or waking up too early. And those are really the parameters that we think of around, trying to quantify our sleep. And then obviously the next day impacts are those, the difficulties that you're having, whether it be at work or if you're caregiving or whatever you're doing, when you've had those issues with your sleep the night before and then you're trying to function the next day, that's where some folks can find things quite debilitating. What we notice in perimenopause and the menopause transition, and even postmenopause, wakefulness after sleep onset, or WASO, is something that is often very much reported as a problem. And that's pretty consistent across studies. If we look at some of what we might consider to be more the diagnostic criteria or different criterion that are used to establish whether or not somebody is truly experiencing insomnia, they do typically look at if somebody is having difficulty getting to sleep, staying asleep, or waking up too early. Often there is the presence, or has to be the presence, of daytime sequelae, because why else would you care? So often it can be distressing and impairing in functioning. And typically if it happens for 3 or more nights per week and 3 or more months in a row. And here we have the chronic insomnia prevalence in Canada. So this was a study done by Charles Moran and his group in 2024, and it's estimated to be about 16%. But now as we go and we look across populations in different groups, you'll see that in the perimenopausal folks and the postmenopausal folks, that there is some differences in terms of sleep disturbances. One thing that we as a Sleepwell team wanted to talk to you about tonight as well is this 3P model of insomnia that's been around for quite some time. But I think it can help folks to maybe sit back and analyze their sleep issues and think about whether what's happening for them is something that's a predisposing factor, precipitating factor, or something that might perpetuate the insomnia itself. So we're just going to look at an analogy. So here in Halifax or Chibuktuk tonight, we had a nice sunny evening and it's beautiful out, and we automatically turn our mind to spring, thankfully. But we also reflect and think about our forests and how lately we've been having some very dry summers. So just to make the analogy with sleep and insomnia, if we have a dry forest and the conditions that make a fire more likely exist, it could be things like a dry forest, lots of leaves and branches on the ground, maybe there's windy conditions, but that doesn't actually start the fire. So if we were to look in the insomnia literature, we might see things like folks that maybe have traits or personality where we tend to worry a bit more, or maybe we ruminate on things. We have high physiological arousal, or already have light. We're a light sleeper, if you will, or maybe genetic vulnerability. Being female is probably also considered within that predisposing factors. So they exist, and just like here, the forest is dry, but nothing is burning yet. So when we think of a precipitating factor, that might be, in this case, as you can see, a very obvious lightning strike. So that's the event that's starting the fire. And, it could be a campfire spark or maybe a dropped cigarette. And in insomnia, what this might correspond to is maybe there's a stressful life event, an illness, maybe a new diagnosis of a long-term pain condition. Maybe it's travel related, or maybe it's related to menopausal symptoms. Perhaps it's relationship problems. So the key idea here is that there's something that might spark to ignite the fire or to trigger the acute insomnia. And then we get into perpetuating factors. So these are the fuel that really keeps the fire burning. After that initial spark, the fire continues because fuel is added. So, there's more dead brush in the woods, and maybe there's some more fallen trees, and maybe the wind picks up and it really, really continues to spur the flames on and spur them forward. In insomnia, this might correspond to when we spend too much time in our bed, or we have an irregular sleep schedule. Maybe we're engaging in napping, or we're worrying a lot about sleep and what's going to happen if I don't get sleep tonight. I'm not going to be able to function at work tomorrow. We might also do things like try to use alcohol or other substances to try to help us sleep. And then we end up in a state of really this conditioned arousal when we're trying to go to bed. And when things perpetuate for a period of time, even though the spark is gone, the lightning storm has long since passed, and it's been gone for weeks, the fires can actually keep burning. And in the case of insomnia, the insomnia can actually turn from an acute problem to something that begins to be more chronic. So if folks on the call, I'm guessing many of you are here because you've experienced this, and I know I have had this happen myself, where you start to think about and make bad associations with what's happening with your bed and with sleep. So, you're not getting to sleep, you're not maybe feeling sleepy when you're supposed to be in bed. Your mind can start to race. You can begin to feel frustrated or worry. I do myself tend to worry that if I don't get a good night's sleep, the next day is maybe not going to go as planned. And what if I can't do what I'm supposed to do? And then in the daytime, I get very tired. I'm sure people have experienced this. You yourself, you might feel like I need to cancel that. I might need to move that. I'm not sure I'm going to be able to do it. And maybe you're engaging in more coffee or taking a long nap. And then evening habits, I'll go to bed early so I can catch up on sleep. I think I've said that myself. I'm sure folks on the call have done that too. Tonight's going to be the night that I catch up. So we can end up in these cycles, which can actually perpetuate the insomnia, and it's more of that kind of conditioned arousal. So what does, this whole thing around sleep and what's a good explanation for it? And I really like the book by Stephen Stahl. He has some really great explanations. And these diagrams seem really simple, but I think in fact they quite aptly point out the complexity that can happen with sleep. And he presents it to us to think about. It's not that you're asleep or you're awake. It's that you're on some sort of spectrum of your brain with arousal. And he also points out that there are many neurotransmitters and different structures and pathways in the brain that are involved with this arousal spectrum. So I really do like the diagram. He points out important information about, there's presence of histamine, dopamine, norepinephrine, serotonin, acetylcholine, also, which is not shown on this particular slide. He does speak to GABA, and what's becoming increasingly popular is exploration of what's happening with something known as orexin and orexin neurotransmitters in the brain that may help to stabilize this state of arousal. And so it also shows me that sometimes I think I might be able to come up with a quick fix, but maybe in fact it's not so simple, and that we're not going to find a magic solution immediately. Folks are probably familiar with these diagrams as well, where, when we think about all the neurotransmitters that are underlying the sleep cycle, we have the sleep cycle where we talk about moving from REM, non-REM. And I think that people probably are very familiar with the circadian wake drive, and that's often a result of inputs to the brain through light, production of melatonin, in the hypothalamus, which can help to stimulate the release of orexin to stabilize wakefulness. And then we also have something called the homeostatic sleep drive, and that's really dependent on the accumulation of adenosine. And I bet you some folks on the call are well aware of an adenosine blocker or antagonist, which would be our caffeine and our coffee. And so when we accumulate adenosine across the day throughout this homeostatic process, so that's kind of like we think about the baseline processes in our body, this leads to a disinhibition of a part of the brain and the release of GABA in another part of the brain to inhibit wakefulness. So it's kind of like the balance between these two driving forces that produces the sleep cycle. And I thought, again, just to aptly point out another really just simplistic, cartoonish type diagram, but it really just does show that throughout the sleep cycle, there is a lot of checks and balances and a lot of different things happening with different neurotransmitters in our brain. For example, some people might recognize that taking an antihistamine, for example, might make them drowsy, and how histamine in the brain might actually be responsible for alertness. So I think it is probably at times really complex. We can try to make things simple, but we might not end up with the exact outcome we were expecting, just because there are so many circuits and communicating parts within the brain. And we continue to learn more and more about what actually maintains that level of arousal and then not when we're trying to get to sleep. So what is happening in menopause then as it pertains to some of those hormonal and neurotransmitter type interactions that we just saw? So I just pulled this diagram from the British Menopause Society. I thought it was just, maybe it's a little bit too overly simplistic, but I just think it shows nicely some of the causes of sleep disturbances related to menopause. And I'm going to ad lib a little bit of details as we go. So there might be some folks on the webcast that have a variety of medical conditions that might, predispose you to sleep disturbances. Maybe you have something like gastrointestinal, reflux problems. Maybe you have a lung condition like chronic obstructive pulmonary disease or something else that might make you feel short of breath at night. As a pharmacist with a pharmacy background, I often talk to folks about, are you taking medications? When are you taking medications that might increase or make you urinate more? That's important to think about. So a classic example of that might be something like a diuretic. There's also some other drugs, for example, some of the diabetes drugs that actually, the mechanism is to make people pee out more glucose. And it's not that they're making them pee more often, but it's just now that they may have more sugar in their urine, and that might actually predispose some folks to infections. And we're going to talk a little bit about that in a minute or so when thinking about if you're feeling uncomfortable when you're urinating. That might be something that you should also talk to your healthcare professionals about. And sometimes that can also impact your sleep. So obviously they have listed here the sleep disorders. So we did talk a little bit about chronic insomnia. Sleep disordered breathing is another one that we will highlight, and that is something that can increase in this menopause transition and in this menopausal phase. And also periodic limb movement disorder, within that being something like restless leg. Lifestyle and stress. So I probably don't need to talk to a lot of folks on this call that this stage in age of life, sometimes being in that sandwich generation, there's a lot going on. People are managing a lot. Aging. So in general, I think most studies agree that sleep quality does decrease with age, mostly due to increased sleep fragmentation. Sleep typically as we age becomes less efficient with more awakenings with advancing age. And I think what often is mentioned in the literature is there is also a shift in the circadian rhythm that we can see with aging, which may contribute to some of that changing in the sleep and awake times in middle-aged folks. Nocturia is, so that's basically if you're getting up to pee during the night. So we talked a little bit about medications over there, but I really want to encourage folks that if they are getting up to pee, that's something that they should speak to their healthcare professionals about. There is this phenomenon called genitourinary syndrome of menopause. I will talk about it in a little bit. But it is estimated that, and this may actually be an underestimation because sometimes people are a little embarrassed to talk about these things, but that 30 to 40% may actually report having urinary syndrome symptoms that are associated with the changes in the hormones in their body. Mood changes are another one, and I think that this is really important during this window in the perimenopause, for example. I think it is what we would call a window of vulnerability for things like mood changes and depression. If you're reflecting on your own life as you go back and you're thinking that, things like premenstrual dysphoria or other things like that were a concern for you, it could be that also during this time of hormone changes, you may experience similar things. So depression, anxiety can occur, and sometimes folks try to figure out, is this a chicken or egg thing as it pertains to insomnia? But definitely, if you're experiencing insomnia and at baseline you have depression or anxiety, then obviously the insomnia is not going to make that any better of a situation. And I think some statistics say that there could be a two to four-fold increase in depression during the menopause transition. And if you have poor sleep, then it's going to make things worse for you. Vasomotor symptoms are also a really important thing to mention. And this is, again, when you think about all the rankings of the system, of the symptoms that can occur during the perimenopause, menopause transition, postmenopause, vasomotor symptoms are important. I think maybe, I'm not sure. I would say back in the day, we used to assume that when folks were experiencing vasomotor symptoms, they didn't, maybe they lasted for a couple of years. I think now we're finding that the median duration may be about 7.5 years, maybe even longer. Some folks can have vasomotor symptoms for 20 years or more. And I think based on what we're seeing from the literature, is that when they start earlier, they may actually last longer. So with vasomotor symptoms, some people are woken up with their vasomotor symptoms. Some people don't even know they've had them, but they might wake up after they've had the event and they're drenched in sweat. So it's very individualized, and vasomotor symptoms can affect people's sleep in a lot of different ways. And then obviously this generic category here called hormonal changes. And so I think with hormonal changes, it is important to recognize, and in the next slide, I'll talk a little bit more about this, where estrogen has been tied to, shall we say, things like co-regulation, or has been implicated in the contribution to the synthesis of other neurotransmitters. So before, in that earlier slide, when I was showing you things like dopamine, orexin in different parts of the brain, estrogen has actually been found to, increase serotonin synthesis and some of the receptor activity. It's also been shown to be involved with dopamine as well. Estrogen is thought to actually also help modulate orexin neurons in the hypothalamus. Another interesting thing, and I'm not sure, some folks might be aware of this, but progesterone itself is also metabolized to a neurosteroid. Allopregnanolone is what you might see in the literature or even on social media. And that can also produce sedating or sleep promoting effects for some people. And they've even found, when looking at things like progesterone, that it might actually impact respiration in general. And so, there's been studies over the years that have been done looking at, the changes in menstrual cycle, even as it pertains to things like asthma symptoms. And so, as I mentioned at the beginning of the talk, I think more and more and more, we're going to start to see, hopefully, clearer pathways and lineages between the physiology of, what's happening in our bodies with these hormonal changes and how they're actually manifesting. Now, I will say that by and large, for the most part, progesterone in postmenopausal folks, if it's used, the indication is really typically for uterine lining protection. And so making sure that folks don't end up with endometrial hyperplasia or too much buildup of the endometrial lining. And so folks that use it for that indication, some do find that they actually do say that their sleep improves, but that doesn't consistently happen with everybody. So I just wanted to show you a recent study that was published, and they looked at a lot of women in the US and Europe. It was a secondary analysis of data. However, it was interesting when pulling out the research when examining the trends with vasomotor symptoms or non-vasomotor symptoms. And are you having disturbances of sleep? So sometimes folks will say, well, if you're not having VMS or vasomotor symptoms, well, you're probably also not having insomnia. So that's not always the case. And just after reviewing all the complex linkages with hormones and sleep, that does make sense. So if somebody was having, in this particular cohort of women, sleep disturbance at least weekly with a yes to any of the following. So it was difficulty falling asleep, waking up during the night, waking up several times, waking up too early, feeling like they were having poor sleep quality, daytime sleepiness or sleep difficulties. What they found was, looking in the perimenopause period, those with VMS, you can see there's quite a high number of folks that were experiencing sleep disturbance. And even if they weren't having VMS, it was still, say 4 to 10 folks. In the postmenopause, the numbers actually went up slightly. So again, as I mentioned earlier, people can still continue to have vasomotor symptoms for quite some time, even in the postmenopausal phase. And for those, that might actually be a contributor to sleep disturbances. But again, you can still have sleep disturbance without experiencing vasomotor symptoms. So that's just something that's important to know. I did want to spend a minute here looking at sleep disordered breathing because, as mentioned, this can increase in the menopause transition. And the symptoms of sleep disordered breathing can include things like snoring, excessive daytime sleepiness, and fatigue. If you're having witnessed breathing pauses, if you co-sleep with somebody, they might actually be able to notice that if you're gasping or you're choking while you're sleeping, or you're just feeling really unrefreshed. And I went to a really interesting presentation a couple of years ago by a sleep scientist in Australia who was really saying that based on all the data that they had collected within their lab, they were noticing that the presentation was different between the sexes and that females might not necessarily, or those assigned female at birth, may be presenting a little bit differently than men and having maybe more morning headaches, mood disturbances, and maybe less likely to report snoring. So again, I think this is one of those areas that's going to continue to evolve over time as we start to learn more about sleep disordered breathing in the menopause transition. If you're if you record your sleep and you're noticing that you're getting up to pee during the night, sleep disordered breathing can actually be another reason why you're getting up to pee during the night. And that might sound odd, but there is a chemical that will be produced by our body, and it's called atrial natriuretic peptide. And basically, what happens is in response to the changes in pressure, changes that can occur when we're not breathing correctly as we sleep, our body secretes this and it causes us to get rid of sodium in water, which means we're going to pee. So that might actually be another flag for you to consider. Restless leg syndrome is a neurobiological disorder, and a lot of folks sometimes lie in bed and feel like they have this undeniable need to move their legs. It can feel like creeping, crawling, tingling, cramping. And another important thing to note with this one is it is important to bring it up with your healthcare providers because for some folks, actually having low ferritin can be one of the reasons that's causing this. And so I think when we're looking at thinking about maybe, for example, abnormal uterine bleeding, if somebody's experiencing things like that, that might also be another flag that if you've been having heavy bleeding, you have to think about things like iron, ferritin, etc. But again, just in general, anybody who is experiencing this, it is good to bring it up with your care providers if it's a cause of your insomnia. So genitourinary syndrome of menopause is something, again, that I did want to mention. 40 to 50% of women can be bothered by these symptoms. It can be vulvovaginal symptoms, so they might experience burning, painful intercourse if you're having penetrative intercourse. It can be painful. Urinary symptoms can go along with that, and that is not an uncommon symptom that people can experience as you can see there. So it can be disruptive to sleep if people are feeling like they're having pain or burning there, and also if they're getting up to pee. So I did mention that before, but here's just a quick refresher. If you're interested, this article, I was also able to find it from the British Menopause Society. It's freely available online. So the impact of insomnia, I think folks on the call probably recognize that there's the daytime impairment impact, but I think what we're finding more and more is that insomnia is a risk factor for a lot of chronic health challenges that are experienced by Canadians. And for many older adult folks that we've talked to, they do get concerned about things like memory impairment and cognitive decline, and other things related to our functioning, such as car accidents. So I think there's a good argument here to be made to treat insomnia. And so what is the treatment approach? So if you're coming to a Sleepwell talk and you've been to one before, it wouldn't be surprising that you're going to see the next slide, which is that the options to treat insomnia. The number one recommended one is cognitive behavioral therapy for insomnia. And then number two is pharmacological options. So now when I say pharmacological options in this section of the talk, I'm really talking about things like sedatives or sleeping pills. Now, if you're experiencing insomnia and you believe that it is related to vasomotor symptoms, then it's probably a good idea to explore that further and talk to your healthcare providers about, is there anything I can do to help managing these vasomotor symptoms. So I don't mean that I'm including those pharmacological options in this particular section of the talk, because by all means, if you think there is some symptoms that you can reverse by treating vasomotor symptoms or whatever else that might be, then certainly explore that as well. But here what we're talking about in the next section is cognitive behavioral therapy for insomnia. And in Sleepwell, on today we're talking about the left side. In many of the Sleepwell resources, we talk about a self-care or a self-help approach, which is really starting to be supported more and more, because we know that at times accessing the different components of CBT-I as a package, as a group, can feel like it's a little bit difficult. And the perception being that maybe the whole package of CBT-I has to be offered by a therapist. But with a stepped care model, I think the majority of experts now support that folks can actually start to do and try some solutions themselves. So that sort of test and try model. And the different CBT-I components are listed there for you. Cognitive restructuring, relaxation techniques, stimulus control, time in bed restriction, and we've actually made that box for sleep hygiene quite tiny, because I think a lot of folks often will go and try sleep hygiene techniques on their own, and it's quite obvious that they can help a little bit, but they're probably not going to be that magic ticket for people that will actually help them to improve their sleep. And when we're speaking about CBT-I, and I will encourage you at this point as well to check out the Sleepwell website or whatever other resource that you found, but ours is mysleepwell.ca. We have some CBT-I resources listed there for you. And really what it's ultimately trying to do is create changes in what you think and what you do. And is there anyone who shouldn't use CBT-I? Well, CBT-I can really be used for most people. There is one or two things that we should note, and that usually involves around sleep restriction therapy or restricting the amount of time folks are sleeping. So if you have a condition that maybe predisposes you to worse outcomes for when you restrict your sleep, then that should be something that's talked about with a healthcare professional. But by and large, for most folks, there's different techniques and strategies that you can try related to CBT-I and those 5 components that might help to improve your sleep. And just to reiterate this, sleep hygiene is not the same thing as CBT-I. So if you have a quiet room and a good temperature of your room, you've reduced your caffeine intake at night, those are all great strategies, but that is in fact not a CBT-I program. As a Sleepwell team, we're confident in recommending CBT-I as the first-line therapy. The majority of the guidelines do recommend CBT-I, and you might be wondering, well, does it work for insomnia? So we did see the British Menopause Society guidelines earlier. They also recommend CBT-I as first line for insomnia. And what a lot of folks often will report is that when using CBT-I techniques for helping with insomnia, it can often help to address those perpetuating factors. And so we'll go through what that could look like shortly. So there has been studies, I've just pulled one example here to show you that yes, indeed, CBT-I, sleep restriction therapy, and sleep hygiene education have been used to look at things like insomnia severity index. So the graph on the left there, you can see that in red it's sleep hygiene education, sleep restriction therapy is in blue, and then in green we have the CBT-I. And out of all 3 approaches, just by looking at the lines, you can see that the insomnia severity declined most in the full CBT-I, but also with sleep restriction therapy. Sleep quality also improved. Sleep latency, meaning how long it took to get to sleep, also was improved. But an important one too that improved across the groups, but most with the CBT-I and also sleep restriction therapy, is that wake after sleep onset, which tends to happen often in folks that are experiencing menopause. There's a variety of CBT-I formats that are available. We can do therapist-guided, hybrid, or self-help. With the Sleepwell resources, a lot of them we do recommend you can try on your own as part of your own self-care approach. And oftentimes people will try it for at least 4 to 8 weeks when they're engaging in self-care. Another issue with therapist guided is that it's often not readily accessible to folks. And although there are efforts to train more people in CBT-I, it's not always the case that someone is readily available to you. So all the more reason that if you're able, try a self help or self-care process. So one of the slides that I just showed you a minute ago there, we saw that sleep restriction therapy, or sometimes it's also known as time in bed therapy, was pretty effective. And we also know that when combined with stimulus control, these can be some of the most powerful tools that folks can use in a CBT-I program. How do you get yourself started? Well, the most important thing to do is to start with a sleep diary and get yourself a couple of weeks of data. We really encourage this because if you're going to see a clinician, for example, you wanted to talk about it, or you want to give yourself some objective evidence to what the heck is happening. What am I doing at night? Why can't I sleep? Where are the problems? Well, what better way to actually put pen to paper and write it down? So this helps you to establish a baseline. It can help you to identify patterns, to guide what you're going to do next, and to also track your progress about your insomnia. So we do have a sleep diary on the Sleepwell website that's freely available for you to print off. We have an example here of somebody named Ginny. Ginny is going to fill out her sleep diary, decides, maybe Ginny and I are working together. Maybe Ginny's working with a nurse practitioner, doctor, pharmacist, whoever it might be, or a friend. You can do it with a friend, deciding to actually complete the sleep diary for a week or two. And mainly, what Ginny is trying to get out of this by filling in the numbers about what time she went to sleep, what time she got up in the morning, how many times she was awake during the night, for about how long. We're getting all this information that can show us what's her actual sleep window. So that's the opportunity for sleep. So it's really the total time that she's spending in bed over the night, whether she's awake or asleep. The time awake, and that's really the time between bedtime and the time you get out of bed. The time asleep, so that is obtained by subtracting the time awake from that total sleep window, or that opportunity to have sleep. And you can also calculate what's known as a sleep efficiency. And really what the sleep efficiency does, it really tells us how much of the time that you're spending in bed are you actually sleeping. And so, if that number was basically 100%, it'd be as soon as you hit the pillow, you're out, and then as soon as you wake up, you're out of the bed as well, which usually isn't possible for most folks. And so usually the target is around 85 to 95%. So I'll just show you here what Ginny did. Ginny decided to fill out the sleep diary for a week back in February. And looking at what a typical night might be for Ginny, sometimes a typical night can be hard to find. So, we make our best effort to select a night that might look like a usual thing. And what we've done here is selected that. We just chose Wednesday. We looked at the time that Ginny went to bed, and calculated the numbers. So thinking about her whole opportunity of being in bed with her sleep window, how much time she spent awake there. So you can see there were periods where she was awake during the night and getting up and awake for 3 different times during the night. We can see that Ginny is also quite an early riser. And as we talked about, that sometimes those patterns can also happen with aging, but it possibly could also be related to her menopause as well. So we would want to ask about that. And we'd also want to know, Ginny, why are you waking up during the night? Is it related to vasomotor symptoms? Are you getting up to pee? Tell us a little bit about what's happening there. And you would want to also record that for yourself if that's what's happening, if that's what was happening for you. So Ginny finds out that her sleep efficiency is only about 76%, and she wants to set a goal for herself to do better. So she would like to get up closer to that 85%. And you can see there that she's done some ratings of her sleep, and overall, she's not really too satisfied because the sleep quality is rated in large part, kind of on the poor side. What about napping? So sometimes I like to make the analogy about napping similar to snacking. You wouldn't have a snack right before you go have your supper because it'll basically spoil your supper or your dinner. And so in this particular case, we can see that, if Jenny's having some late night naps, then that might be something that is also affecting her drive for sleep or her body's biological need for sleep. So when we look at her diary, we can see some patterns here Ginny seems to have a lot of differences when it comes to what time she actually goes to bed. She's spending 30 minutes per night before lights out. As some of the kids would say these days, I'm not sure if she's doom scrolling or not, but some folks can sometimes get into bed and end up into that habit. Is she unable to fall asleep? Or sorry, she's unable to fall asleep for 4 nights, less than 30 minutes. She's having awakenings that are greater than 15 minutes, 5 nights across the board. She's spending some time in bed after she was waking up in the morning. So, we often say once you set your rise time, don't languish in bed, set the rise time and just get out of bed. Her sleep duration does look a little short, and therefore, with all these factors combined together and calculating her sleep numbers, she doesn't have a good sleep efficiency. And there's some simple things that you could probably do is try to avoid napping. So we're talking to Ginny a little bit more, and she wants to set herself her own sleep prescription or her sleep schedule for next week. What time does she want to wake up? Well, she still wants to get up early. And again, maybe Ginny has to get off to work. So 5 a.m. is a good time for her. But when we look at what time she wants to go to bed, 8 p.m. suits me, is what she says. And oftentimes, some folks, have a certain, concept of the amount of time that they need for sleep, and they're trying to do that trick of, well, maybe I'll go to bed tonight earlier, and this will be the night. This will be the night that I fall asleep. But based on what we saw in the patterns, a later bedtime for Ginny is probably best. So Ginny thinks, yep, that's good. I've talked to my friends about this, or maybe a healthcare provider, and we're going to try and do a later bedtime. So 9:30 p.m. And on our Sleepwell website, and also in other books and resources that you will read, there are some things around stimulus control that Ginny can try. So she's going to avoid napping or dozing. Ginny is going to stay awake until her bedtime, so there's no use in getting to bed if you're not sleepy, because that can actually reinforce that conditioned arousal cycle, where you might stay frustrated with the fact that you're in bed and you're not sleeping. And there you go. If not sleepy, stay up past your bedtime. Get into bed only when sleepy. If you wake up or while you're trying to get to sleep and you're not to sleep yet, it's important to actually leave the bedroom, leave the environment, get out of bed. And that usually is if you've been lying there for about 15 to 20 minutes. Go to another room, a dark place if you can. Do something really boring until you feel sleepy, and then go back to bed. Setting a same rise time is often very useful. And again, even if it's the weekend, having the same consistency across the board. Try not to lay in bed in the morning or languish in bed. And use your sleep diary every day. And Ginny's going to do that. And I think it's important to do that without worrying about being exact. So Ginny comes up with her sleep diary. She's recorded all her numbers again. We pick a typical night. And she redoes her calculations. And just by making those simple adjustments, she went to the Sleepwell website and calculated her sleep efficiency and got a sleep efficiency of 84%. So she was quite proud of herself just by making some of those simple changes. And she's thinking, I think I actually want to try more. I want to do a little bit better. And so she can also adjust her bedtime routine. On the Sleepwell website, you can see some interpretation there, and they made a recommendation of moving the bedtime 15 minutes later. So if you're curious about, making some adjustments to your bedtime, and again, just a caution, make sure that sleep restriction therapy or changing these types of windows is appropriate for you. But there's information there on how you can change that. And Ginny decided, you know what, I am spending quite a bit of time still awake in bed. I think instead of 9:30 and 15 minutes, I'm actually going to try and push it back to 10 p.m. And so that is something that's fully within Ginny's control. She's looked to say, what does my week look like next week? What do I have planned? Based on the amount of time that I'm actually spending in bed awake, I still think that this 10 p.m. bedtime is probably a pretty safe bet. And so she also establishes some sleep rules for next week to think about trying to increase that sleep drive and using some of those stimulus controls. And so she's going to consistently think about things like limiting the amount of time in bed. So when she gets up, if she gets up to pee and she can't fall asleep immediately and she's lying there for more than 15 to 20 minutes, she's going to get up and get out of bed. An important thing to note just on the sleep restriction therapy, that generally people don't recommend that you spend any less than 6 hours in bed. And there's some more information and tools and tips and techniques on the Sleepwell website with respect to this and how you can make those adjustments, but just a caution that no less than 6 hours in bed. Some folks can experience some mild sleep deprivation when they are making these changes. And so it is important to look ahead and say, what do I have in my schedule? What do I think is feasible, realistic? And it's not that you have to jump in like Jenny did and make a full half-hour change, but sometimes smaller changes can be effective and you might notice improvements in your sleep. In terms of pharmacological options, I'm not going to spend a lot of time on this. I just wanted to let you know that, for example, using the medication example, some people have possibly misconceptions about what they're going to get out of using medication. So this is an example using zopiclone, where we see two curves overlapping when we look at total sleep time. And the difference between using a Z drug versus a placebo, so placebo might be a sugar pill, so to speak, that somebody's given them in a trial, might be a difference in 23 minutes. In terms of getting to sleep faster, similar type of situation, it actually might be a 10-minute difference. And so when we think about some of the context and considerations for sedatives, some of the work on the Sleepwell website and what you'll see is we do notice that there is higher rates of sedative use in Atlantic Canada in particular. Females have a 50% higher usage rate than males. Sleeping pill use does increase with age and often in more vulnerable groups who are 75 and above. Some sleep medications, technically, if they are to be used, are often indicated in the shorter term, as when we're talking about drugs like benzodiazepines and Z drugs. But unfortunately, 1 in 4 new starts will become chronic use. And this can also happen not only in community, but also in the context of hospital practice. Benzodiazepine use has been reducing over time, but we also see other agents being used to manage insomnia. We often put up the sleeping pill risks, and again, a lot of these are relative risks, but for the older adults that we often talk to, they tell us that they want us to let you know that they're not completely benign and that things like falls and fractures are a concern. Things like cognitive impairment and some of the associations from observational studies that have been made with these medications and memory are concerning to them. And also things like impairment. For some folks taking medications that are things like the Z drugs or the benzodiazepines, when they try to stop the medications, withdrawal insomnia can actually be one of the most notable adverse reactions. And so that's why it's important to come up with a plan for yourself, and you can work with your healthcare providers to help with that. So I will end on this slide. We have Faye. Faye is somebody that contributed her story to the Sleepwell website and had been taking sleeping pill medications for quite some time, temazepam, and was able to actually gradually reduce and stop those and use some of those techniques to actually get a better night's sleep.